All right, it is now 10:15. Welcome, everybody. Good morning. Thank you for joining us. Today, this session, we're going to talk about complement and the novel medications. I think it will be a good review of sort of what the complement cascade is and the new medications that are used to target some of those sites. So I'd like to introduce Dr. Anna Dutton. She completed her PharmD at the University of Tennessee Health Science Center in Memphis. She has been in her current role as clinical pharmacy specialist within the Division of Nephrology at Tufts Medical Center in Boston since 2020. She provides medication management support both within the nephrology clinic and outpatient dialysis unit. As well as I'd like to introduce Dr. Craig Gordon, who is a professor of medicine at Tufts University School of Medicine and a nephrologist at Tufts Medical Center. Dr. Gordon is the director of the Polycystic Kidney Disease Center of Excellence and the director of the multidisciplinary thrombotic microangiopathy team at Tufts. He has served on the evidence review team for multiple KDIGO guidelines, including the 2025 guidelines on ADPKD, the upcoming KDIGO guidelines on AKI/AKD, and on chapter updates for the KDIGO guidelines on glomerular disease, including lupus nephritis, ANCA vasculitis, IgA nephropathy, and pediatric nephrotic syndrome. Dr. Gordon's clinical practice focuses on PKD, glomerular disease, and thrombotic microangiopathy. Before they get started, I want to just remind you, for CME credit, you do have to do the pre-test and post-test, and you can do that right in the app. If there are questions that come up during the talk, put them under the polls, and we can certainly get to them at the appropriate time. All right, with that, thank you.
While you're getting to the podium, I just wanted to ask really quickly before Craig gets started, can we just to see who's in the room, can you raise your hand if you're an APP? Anybody APP in this room? Pharmacist? Great. Other nurse, technician, social worker, dietitian? I didn't name it? Okay, great, thank you.
All right, well, thank you, Allison, for the very generous introduction, and to the organizers for the invitation for the two of us to speak here. Anna and I are going to try something a little bit maybe experimental and sort of go back and forth through the talk rather than me launching into 45 minutes of complement pathways and biology, which you could all imagine you'll all be thankful for. So briefly here, the two of our disclosures. And our learning objectives for the talk is to review the current understanding of complement pathways and targetable sites for nephrology conditions, understand the mechanism of action, the benefits and harms of various complement blocking agents approved for specific conditions in nephrology, and recognize some practical strategies for the initiation and ensuring the safety of these novel therapies. So I will begin with a review of the complement pathway, but my goal here is to not overwhelm you as often we do with lists of big B, little b, and people rattling off the names as quickly as possible, but to really try to give a big 30,000-foot view, perhaps, of the complement cascade. So I think my arrow is not appearing here, so let me do it with the pointer. So maybe my pointer's not working.
The pointer's really light.
Yeah, I don't think it works, but I'll call your attention with words to what we're seeing. Actually, maybe I can. No, it's okay. I thought there might be a pointer feature. But you can see on the left-hand side are the three major pathways, the lectin or mannose binding lectin pathway, the classical pathway, and the alternative pathway. The lectin and classical pathway are usually triggered. These are pathways involved in fighting off infection, right? So the lectin and classical pathways respond to the presence of antigens and themselves go from basically zero to revved up. The alternative pathway is actually, via what's called the tick-over phenomenon, is constitutively active. So this is active all the time in all of us, and upon exposure to a pathogen, then revs itself up in response to this. You can see all three lines there coinciding on what's called the C3 convertase. And what this does is it converts C3, which is a little bit to the right and up from there, to C3a and C3b. C3a, you can see on the bottom, has interactions with the glomerular endothelial cells, the mesangial cells, as well as the podocytes. C3b then gets fed forward into the C5 convertase, and you can see all the big B, little b letters underneath there. And that C5 convertase converts C5 again to the upper right to C5a, which is a very potent anaphylatoxin, so recruiting all kinds of inflammatory cells. And also the beginning with C5b of the membrane attack complex. And I think just having a recognition of this information when we think about the complement cascade is really important. One thing I neglected to mention is the amplification loop. So when C3 convertase converts C3 to C3b, there is a feedback that results in a revving up of this system. If you imagine a person's been exposed to a pathogen, the complement system revs itself up very, very, very quickly, deals with the infection, and then should tamp itself down. So let's talk about the tamping of itself down. This is just a different figure with different orientations. So you can see classical lectin and alternative pathway in the top. And in this one, as we work our way down from, let's say, starting with the alternative pathway to C3 there in the middle, C5 below, and the membrane attack complex at the bottom, we can start to see some of the inhibitors of this pathway. If you imagine the alternative pathway of complement, if it gets revved up in the place of infection, we need to slow it down. And this is where, if you see to the top there, factor H, and to the bottom, factor I, are among the several different proteins that sort of slow the system down. People with mutations or autoantibodies to these components in the face of the alternative pathway being activated can be basically at risk of thrombotic microangiopathy following a trigger. In the green and sort of blue-colored circles at the top are proteins that push the pathway along and increase the flow through these pathways and the conversion of C3 to its subsequent byproducts and C5 as well, and those are potentially targetable sites. What may not be easy to see in this figure, but is also important, is the various circles that are hatched instead of solidly lined are things that we can use when we're trying to assess the functional components of the complement cascade. And we'll give a highlight to, we'll use one of our cases a little bit later to emphasize what we're talking about there. So it's a really exciting time in complement. We have inhibitors to basically all of these components that have been that are either FDA approved or under investigation. So you can see at the top, inhibitors of the alternative pathway include inhibitors of factor B, including some that we'll talk about that have been FDA approved, inhibitors of factor D, as well as C3, including agents that are also FDA approved. There are inhibitors of the classical pathway, as well as inhibitors of the mannan lectin binding pathway that have been studied. And then finally, I think where we all started with this was inhibitors of terminal complement, inhibiting C5, the membrane attack complex, as well as C5a. If you look in that third column, you can see the disease states that have been either studied or approved, and it's all over glomerular disease. So this is why in a lot of this conference, there's been a lot of talk about complement blockade, because it affects some of the most important conditions we see in nephrology, whether we're talking IgA nephropathy, C3G, et cetera. And we're going to use some cases to sort of highlight this point. So this is a slide that's a little bit busy, but I do want to use it as a way to sort of think about different mechanisms of complement causing renal conditions. So if we start at the bottom there, that's C3G and AHUS, or complement-mediated TMA, as many like to call it. And basically in those conditions, in many cases, the complement system is the major driver of things. If someone has a complement factor H mutation and they're exposed to one of the triggers that we'll come to a little bit later that can trigger complement activation in the alternative pathway, and they don't have a functional inhibitor to slow it down, we can end up with destroying the pathogen and with a subsequent damage to the kidney. Same thing is true in C3G if it's an inherited form of C3G. We'll talk also about acquired autoantibodies. If we shift, to the top right, I suppose, is immune complex conditions can trigger complement activation as part of the pathogenesis of the damage to the kidneys. We'll talk about IgA nephropathy as a paradigm for this a little bit later. And then finally, just below that, ANCA vasculitis. We'll discuss in more detail later how C5a is an important part of the pathogenesis in this vasculitis. So just a nice way to think about this. This comes from KDIGO and basically sort of emphasizes conditions where complement dysfunction is really of primary importance on the left and sort of that redder side of things, versus those where complement dysfunction is a secondary driver of injury. So you can see conditions like AHUS or C3G and primary immune complex MPGN are entities where complement really is a massive and important part of the pathogenesis and something we really need to tackle medically. The next set of boxes are ANCA vasculitis, lupus nephritis, I suppose I should say, IgA nephropathy, antiphospholipid antibody syndrome, and membranous nephropathy, where we are studying or have developed treatments that block complement to treat these conditions. Moving to the right-hand side are conditions where complement biology may play a role, but it's not an absolute guarantee that complement blockade is going to have a valued effect in these conditions. And so finally, before we turn to cases, I think this is a really important slide to think about how we're using, how we use complement blockade. So in that figure to the left where it says complement-mediated diseases, these are diseases where the complement is the driver. Think about complement-mediated TMA or AHUS. Think about C3G when it comes from a genetic mutation. In these conditions, our job is to really inhibit the complement damage to the kidneys. On the other side of the diagram is really where complement is a downstream effector or a damager of the kidney as a result of some underlying disease, in many cases autoantibody mediated. In here you can think about an autoimmune cause of C3G, you can think about IgA nephropathy, et cetera. And in these conditions, and I think our cases today are going to highlight some of the nuance here, our job is not just to block complement, because that's just blocking that right-hand side where the damage is occurring. We simultaneously need to reduce the antibody formation. And I think one of the errors that's made in some of these immune complex conditions is to look at a case, say, okay, we've tried something that reduces antibody formation, it didn't work. Now we try something that blocks complement, and it doesn't work. And we don't think the way we do for many conditions in nephrology where we need to do both simultaneously. We wouldn't treat lupus nephritis with just CellCept without prednisone, or prednisone without CellCept, right, to use an extreme example. So let's turn to our cases. It's just another figure to emphasize the pathways. Again, if you look, there is the alternative in the upper right, working our way down to C3, C5, and the membrane attack complex. And specifically, we're going to talk about the FDA-approved treatments, which include iptacopan, the inhibitor of factor B, pegcetacoplan of C3, the two C5 inhibitors, eculizumab and ravulizumab, and avacopan, the C5a inhibitor. So we're not going to make these mysteries. The cases are going to be sort of slam dunks. So we're going to begin with a complement-mediated TMA case. And this is a case from our medical center, maybe about 5-6 years ago now, who's a 37-year-old male, really no medical history at all, actually a graphics designer who was visiting Boston for some graphic design thing and came to the ER because he'd had several weeks or months of a headache and was found to have a blood pressure of 240 over 140. He was immediately admitted because of that, and also a creatinine of 17. And when routine labs were done, his hemoglobin was low at 7.7, platelets low at 72. At Tufts, we have a TMA team. Our TMA team has done a lot of educational efforts to say if you see reduced GFR, anemia, and thrombocytopenia, send an LDH and haptoglobin. So this was sent actually immediately. And his LDH was elevated at 929, and haptoglobin was undetectable. So the question in these cases is always, is this hypertension driving MAHA, microangiopathic hemolytic anemia, or is it TMA with secondary hypertension? And one of the clues that it might have been a complement-mediated TMA is that the features of MAHA persisted after we got his blood pressure under control in the ICU. And because we didn't know anything about the man, we underwent a workup of secondary causes of TMA, all of which were negative. Given the creatinine was as bad as it was and his GFR was so low and he was symptomatic, he initiated dialysis. And we subsequently performed a kidney biopsy, which showed vasculopathic changes, severe endothelial injury, and microthrombi in the smaller arterioles, and very little scarring, 30 to 40% interstitial fibrosis and tubular atrophy. So this was a potentially salvageable kidney, but the interpretation of this, I'll talk about the microthrombi as a big clue, as you'll see in subsequent slides, was that this was a primary complement-mediated TMA which needed treatment. So I alluded earlier to the question of hypertension with TMA features versus TMA with hypertension. This is a bit of a diagnostic conundrum. But if you begin at the top of this figure, when we face a patient with malignant hypertension and microangiopathic hemolytic anemia, we first obviously try to control their blood pressure, begin the evaluation of TMA with assessing with LDH and haptoglobin. On the left-hand side, if appropriate and it makes sense, we undergo a diagnostic workup for secondary causes of TMA. On the right-hand side, if appropriate, a diagnostic workup for secondary causes of hypertension. And if these two are negative, now we're starting to move into a situation where a complement-mediated TMA versus a hypertension-induced MAHA becomes the question. So if you look at the boxes on the bottom, the yellow and green box, these are features that point you towards one way or another. So people with complement-mediated TMA, on average, are more likely to be female than male. The converse will be true, by the way. I'm reading the yellow box, but the converse would be true in the green box, the opposite state. Complement-mediated TMA more likely under the age of 45, such as our patient. If there's a family history of TMA, this seems self-evident, right? It sort of clues you into a genetic underlying disorder. We did not have that information in our patient. In the event there's a severe AKI, where the serum creatinine is greater than 5, where dialysis initiation is needed, so our patient meets this criteria. Severe TMA features, so very low hemoglobin or very low platelet count. Again, our patient met those criteria. And then the absence of a known history of hypertension, not listed here, is things like echocardiographic evidence of like left ventricular hypertrophy, which might suggest chronicity. Other clues are the low plasma C3 level if present, as well as if you're able to stain the renal biopsy for the C5b through 9, the membrane attack complex, that's going to point you towards complement-mediated TMA. And then finally, the presence of the microthrombi, as we saw in our patient, in the glomeruli or in the microvasculature of the glomeruli. In these circumstances, we recommend anti-C5 therapy. And let me now open up a question. So what would be the best treatment at this point? If people don't mind taking a moment. Wait a few seconds. So would you use eculizumab, plasma exchange, mycophenolate, or rituximab? I think I might have given it away in the last slide, plus not to mention the name of the talk. But yeah, in these circumstances, plasma exchange will work somewhat. Eculizumab is the treatment of choice. Okay, we need to do something that blocks terminal complement. If ravulizumab was listed here as a choice, that would be a very reasonable one. So again, what does TMA look like? Microangiopathic hemolytic anemia, so the haptoglobin's low, the LDH is high. We have schistocytes on the peripheral smear. We have thrombocytopenia. About 40% of people will have low C3, not all, because what's happening in thrombotic microangiopathy is often occurring at the cell surface level, not in the systemic circulation. So some people can have a low C3, most don't. We want to rule out TTP with Adams TS13 activity, rule out in the appropriate patients Shiga toxin positivity, and now we have complement-mediated TMA or atypical HUS. There's an enormous list of secondary causes, including infectious on the left, certain cancers, both solid organ and hematologic, in the right setting pregnancy, in the right setting autoimmune disease, kidney and other, and actually solid organ as well as bone marrow transplant, cobalamin deficiency, and actually a large range of therapeutic and as well as illicit drugs. In our patient, we did a very limited workup, right? We didn't have to think about cancer. There's no reason to suspect that. Obviously wasn't pregnant, so we were really looking at this question of malignant hypertension there in this sort of orange color versus TMA. You have to rule out TTP with Adams TS13 testing, and if these tests are negative, you don't have to go on an exhaustive search, checking for Coxsackie virus if they don't have a compatible clinical story, but you want to do a reasonable search for secondary causes that are relevant to your patient. If you don't see that, you don't see TTP, now we're dealing with complement-mediated TMA. And I think with that, I'll turn things over to Anna.
This is where I All right, well, as the pharmacist component of this presentation, I get the pleasure of talking through some of the practical implications of what we want to think about with these 5 complement inhibitor therapies that we're going to discuss today. Like Craig mentioned, we're just going to talk about the ones that are currently approved, but as you know, there's lots more on the way. I'm going to use this type of slide, as I introduce each of these drugs, and then we get the pleasure of going through the approval data, the trial data that supports why we now have these. So you'll recognize that slide on the side, or that figure on the side Craig went through earlier. But starting with eculizumab, this is sort of our grandfather complement inhibitor, been around since 2011. It is a humanized monoclonal IgG antibody that targets C5. So as mentioned, it's working terminally in the complement pathway. So prevents the cleavage of C5 into C5a and then C5b, which C5b goes on to form the membrane attack complex. So working distally in this pathway. It is an IV medication, so you give an induction of a loading dose every week for 4 weeks, and then the maintenance phase starts. Maintenance phase is every 2 weeks, but it actually starts at week 5. So it's 5 weeks in a row, and then it goes to every 2 weeks. So that's how this one is dosed. I'm gonna spend just a couple minutes here because all of them have a REMS, with the exception of Avacopan, all of them have a REMS associated with them. So any of you that are less familiar with REMS, that's risk evaluation and mitigation strategies, and it's basically protections that are put in by the FDA when medications are brought to market that have risks associated with them. So these REMS programs can have different components depending on the risk that's associated with the medication. Could require lab monitoring, vaccinations. There might be a REMS related to pregnancy status. So there's lots of reasons why we might have a REMS. But for these types of medications, as one would expect, working in the complement system, in our innate immunity, it's risk of infection, particularly with those encapsulated organisms, Neisseria, strep pneumo, H. flu. So the requirement for these medications is around vaccination and antibiotic prophylaxis. So we'll talk about that in its own moment in this presentation, but just for now, you'll see this come up on all of these slides. And REMS involves a few pieces. So these medications are not quite as easy to prescribe. It's just like sending a medication and a script in the EHR to the local pharmacy. This one specifically, being IV, is approved through the medical benefit. So like any of our other infusions that we're giving, iron or other things, it's approved through the medical pathway. It does require prescriber enrollment. They're online, the forms are online, they're pretty easy to do, but you do have to be enrolled before you can prescribe this medication. And then you have to vaccinate your patients. In this REMS specifically, just calls out requirement for meningococcal vaccines, but I will say in general, and you'll see with the newer agents, they require meningococcal and pneumococcal vaccines, and we do that standardly for our patients on any complement inhibitors, and we'll talk about why. We also vaccinate against H. flu, not explicitly called out in the REMS, but again, it just makes sense. So that's a little bit of information on eculizumab, but let's talk about how it got approved, because This one was approved in 2011, as I mentioned, so prior to this era that we're in now, after all of the work in the nephrology community to get these surrogate markers so that we can bring our glomerular disease drugs to market faster with UPCR surrogates and EGFR slope. So this was before the days of all of that. So the approval of eculizumab was based on a few small, single-arm, open-label phase 2 trials where all the patients received eculizumab. I have some of the figures from 2 of the studies up here, and really just wanted to point out that the approval of this medication came from the findings with normalization of the hematologic parameters, so those MAHA features, as well as recovery of kidney function. So you can see in trial 1, I know it's small, but on the top row is trial 1, you can see the platelets recover quickly within the first weeks of starting eculizumab therapy, and then the GFR takes a bit longer to recover, so a few months, 3 to 6 months, you see that GFR response. And then on the bottom is a table from one of the other studies, again, just wanting to highlight initiation of therapy is like right there in the middle, that line in the middle above the word weeks. So, you see GFR decline prior to starting therapy, therapy has started, and you see that GFR comes up over a few months. All right. You want this one? I can just do this part. So with our patient who, was admitted, started on dialysis, we started eculizumab in him. After we started it, his LDH, haptoglobin, platelets, and hemoglobin all normalized within days. So as expected, that responded very quickly. He was discharged from the hospital. He was still on dialysis, but his urine output was picking up. He was on a Tuesday, Thursday, Saturday schedule of dialysis. He did complete the 4-week loading dose as described, and then began the maintenance dose every other Friday. Remember, he's doing this on top of 3 times a week dialysis. As Craig mentioned, he has a job as a graphic designer. He reported that this, was really cumbersome to quality of life. So they at the time made the decision to convert him to ravulizumab. So we'll spend just a couple minutes talking about ravulizumab, very similar to eculizumab. Longer acting is the difference. Instead of 2 weeks, it's every 8 weeks. Also is a C5 inhibitor. Also a C5 inhibitor, so works in the same place. The difference between these 2 medications from like a practical standpoint, both are IV, both go through the medical benefit, both given in infusion centers or via home infusion. But this one's weight-based, so that's the difference that I really want to point out practically when looking at starting a patient on ravulizumab. It's a one-time loading dose, weight-based. You can see the different categories here. And then the maintenance dose starts at week 2. So you get your loading dose at week 0, maintenance dose starts at week 2, and then it's every 8 weeks after that. And then actually these 2 now have their same REMS exist, and their REMS is actually combined. So it's if you enroll in one, you enroll in the other. So once you enroll to prescribe eculizumab, you can also prescribe ravulizumab. And then the same other requirements. Ravulizumab was approved in 2019, so a few years later. Similar approval pathway. It was 2 single-arm phase 3 trials that led to its approval. Again, basis of normalization of those MAHA features and the recovery of kidney function. Here, one of the primary outcomes in one of the studies was looking at % of patients that had the complete TMA response. So that was included normalization of the hematologic parameters as well as kidney function recovery. It was measured as a 25% increase in serum creatinine, so not all patients got that robust of a GFR response, which is why about 60% had complete TMA response in this trial, but a much higher proportion of the patients had the hematologic response. And they had GFR recovery, just not that high. So you can see here, as expected, platelets increase, LDH drops, hemoglobin increases, and then you can just see the GFR come up as well. All right. I think it's back to you now.
Okay, excellent. For patient convenience, he was switched from eculizumab to ravulizumab. We're very gratified to see his urine output continuing to improve. There was minimal intradialytic weight gain. We noted declining BUN and creatinine, did a formal 24-hour urine, confirming a GFR in the 12 to 15 range, and he's been off dialysis now with a GFR of around 15 since 2022. Continues with ravulizumab to the present day. In 2022 was referred for transplant is listed, accruing time, but there's been absolutely no progression of his GFR in the last, I guess, 4 or 5 years. Regarding the etiology, genetic testing revealed what was a variant of uncertain significance in C3. I'm not sure if we've called to check if that's been revised. A VUS basically means there's not published data that this mutation is associated with the condition, but there might very well be in the subsequent years to come. But the predicted pathogenicity genetically, when they try to evaluate what the protein would look like with this mutation, the predicted pathogenicity is high. So that's him. So let's turn to C3G. And our second case is actually also a relatively recent case, actually is a recent case compared to the other gentleman. It's a 49-year-old woman with hematuria, proteinuria in the range of 1.8 to 3.4 grams per day, and with declining GFR. Obviously, in the clinical practice, we have no idea we're about to diagnose C3G, so we send off a full serological workup looking for lupus and viral hepatitis, et cetera, all of which was negative. And back in March of 2025, she underwent kidney biopsy, which demonstrated a membranoproliferative pattern of injury with diffuse global C3 staining on immunofluorescent microscopy. This was rated at 2+, and there were absolutely no other immunoglobulin stained for at all, essentially making the diagnosis of C3G. Electron microscopy demonstrated a moderate degree of electron-dense deposits. And this person underwent functional complement testing, and this is going to be a very complicated slide to look at, but I really want to emphasize to this audience that without this information, we are kind of flying a little bit blind as far as treatment. So it's not going to be without a pointer that easy, but if you go to the bottom part, you can see soluble C5b through 9 was elevated, suggesting activity of the membrane attack complex. If you move over a few to the left, the factor B, big B, little b was elevated, again suggestive of complement activation. To the far end of that row, the C3 level was low. And the key finding in the upper corner, the upper area under autoantibodies in orange, is an extremely high level of an autoantibody to factor B. So let's talk treatment. In addition to treatments to lower the factor B autoantibody, which of the following would be the best treatment at this point? Would it be eculizumab, ravulizumab, iptacopan, or rituximab? I'll give it a moment or two for people to vote. And so, yeah, I think the majority seem to be weighing towards iptacopan. If we had listed pegcetacoplan, that would have been also a reasonably correct answer. In fact, my talk at noon today, I put both into people. There's 2 correct answers. But in 2026, one of those 2 agents is a better choice than distal complement blockade. So if we do still have some people with C3G at our center on C5 inhibition, including someone who I'm sort of linked to still on eculizumab. I'm trying to make that person switched because, yes, it may work, but it's probably wiser to block where the action is, higher up in the complement cascade in C3. So just to differentiate the complement-mediated TMA we just spoke about in the C3G we're about to, the atypical HUS is really an acute presentation similar to the patient I presented, whereas C3G is chronic. Both are rare. If both involve the complement, although, as I mentioned earlier, AHUS is occurring at the endothelial cell level. This is why the complement levels aren't always low, whereas C3G is occurring in the fluid phase. And in fact, up to 75% of people, and I would imagine it should be even higher, would have low C3 levels as compared to about 40% with AHUS. There's a number of triggers of AHUS. You saw that very complicated diagram I presented. The primary trigger of C3G is thought to be infection. And then importantly, although AHUS is a very acute onset and without treatment, they're virtually 70% or more are going to end up requiring dialysis. C3G is more insidious. The GFR keeps declining over time, but with a really terrible outcome of about 50% progression to kidney failure in 10 years. So very, very serious disease, just moving more slowly in front of our eyes. C3G has a very high risk of recurring after transplant. AHUS may recur, but not as, it depends a little bit on its pathogenesis. And I think with that, I'll move on and turn things back over to Anna.
Right. All right, so first we'll talk about iptacopan in the context of using it for C3G, because the way we've structured this, we're talking more upfront about our, primary complement-mediated disease, and then moving to diseases where complement has a role but maybe is more a driver of secondary inflammation rather than the primary target. So iptacopan, if you're probably also familiar, is also approved for IgA nephropathy, so spoiler alert, we will talk about this again. But for the purpose of C3G, just a reminder that iptacopan is a factor B inhibitor, so working in the alternative pathway, which is where C3 originates from, and it then goes on to form part of the C3 convertase, which then is responsible for some of that amplification that Craig talked about earlier, making it a prime target for this disease. It is an oral medication, so it's 200 milligrams twice a day. So unlike eculizumab and ravulizumab, this one is approved through the pharmacy benefit like our traditional oral medications are. It does have a similar REMS, so requires prescriber enrollment. And then, as I mentioned, these newer medications that have been approved require meningococcal and pneumococcal vaccines with antibiotic prophylaxis. And we'll get into more of the nuance about antibiotic prophylaxis and why we do and what we do, but it's only required in the REMS to prophylax with antibiotics until the patient has received all of their vaccines, which takes about 6 months, and then 2 weeks after that. And then you can stop antibiotic prophylaxis. I'll say, practically speaking, it's not always stopped because we know that patients, even with vaccination, are still at risk of meningococcal infection, but the REMS is specifically stated to say until vaccines are completed and then 2 weeks after. So this is the study that led to the approval of iptacopan for C3 glomerulopathy. This is the APPEAR C3G trial. It was published in 2025, I believe, so fairly recently. So let's talk just a little bit about this medication, because this is the first one that we'll talk about that used our newer approval pathway with the surrogate endpoints that we have. So patients that were included in this trial for iptacopan and C3G were adults with biopsy-confirmed C3G on maximized stable RAS inhibitor therapy and background immunosuppression. So they could have been on mycophenolate or steroids or combination, and they were stratified based on what they were on as background immunosuppression. UPCR requirement was 1 gram per gram, and eGFR had to be at least 30. So patients either received iptacopan or placebo, and this was a 6-month trial. So they were in the 2 groups for 6 months, and then there was an extension period where all patients who received placebo were converted over to iptacopan, and then they were followed for 6 more months. So extension phase for another 6 months. As I said, primary endpoint UPCR at 6 months, and then there's several secondary and exploratory endpoints that I have listed here. I just want to point out, who we're working with, the patients we're working with in this study, right? So this is a young patient population, age in their 20s, 26, average age in iptacopan group 29, or almost 30. In the placebo group, more male than female in this study. Baseline 24-hour UPCR was 3.3 grams in the iptacopan group and 2.6 grams in the placebo group. And baseline GFR was preserved, so 90, GFR of 90. You can see breakdown between who had C3 glomerulonephritis versus dense deposit disease, more with C3 glomerulonephritis, about 2/3 with that. And then about 40% of patients in each group were on a background of immunosuppression with mycophenolate, low-dose steroids, or both. All right, and so here is the primary endpoint data. So you can see on the left-hand side, this is the change in the UPCR in the iptacopan group versus the placebo group. iptacopan obviously on the left here, placebo on the right, and you can see the UPCR was 35% lower in the iptacopan group in this study. I like to look at the change in protein over time. I think it's helpful when we are educating patients. We're starting them on these therapies to help them know when they can expect to see the response. So you can see iptacopan group here is shown in blue, placebo group shown in red, and you can see there that red group then gets converted to iptacopan in the second half of this open label extension. But you can see about that 30% reduction in UPCR. It happens about day 90, so about 3 months, you can expect to see that drop. And then it's maintained throughout the follow-up with a decrease of 40% from baseline by the end of 12 months. And then also, you see in the group that was switched to iptacopan, they then have the same response, 30% reduction from month 6 to month 12. And then I put this in here because, we like UPCR, but we really care about GFR. This is just a 6-month study, so this is not long enough to really evaluate the impact on kidney function. But I think it's important to note that in the iptacopan group, you can see there is stabilization of GFR here at the top. And then at the bottom shows what the GFR trajectory was prior to starting therapy. So that dashed line is when therapy started. So you can see GFR is declining. Then patients are started on iptacopan, and you have that stabilization. So promising. So more to come with GFR data. And then lastly, here's the adverse events. We expect infectious-related complications. There were no serious infections from encapsulated organisms in this study. Again, 6 months, so not that long to tell, but a good sign. Most adverse events were mild or moderate in severity in this study. I think, you want me just to?
Yeah, I can.
Okay, just do it from there.
So just the first 2 bullets are from the original slide, but basically her treatment course after the biopsy, she was initially started with mycophenolate. This follows what's written in UpToDate and many other guidelines as far as treatment of C3G prior to the advent of iptacopan and pegcetacoplan. Had really no response to mycophenolate. Subsequently, this is a patient of my colleagues, started on iptacopan and had only a modest improvement in proteinuria. And as a result, the decision was made to initiate pegcetacoplan. I myself wasn't involved in that decision, but it's a launching point for us to talk about the next drug.
So the other medication that is approved for C3G is pegcetacoplan. This one is also approved for IC, or immune complex MPGN, which makes sense based on its mechanism. It's targeting C3 right here where the pathways converge. So whereas C3G originates from the alternative pathway, IC MPGN from the classical pathway, working, a medication that works where they converge makes sense. So it inhibits C3 and its activation fragment C3b. It is, this one's interesting, it's dosed as 1,080 milligrams subcutaneously 2 times a week. And it's administered as an on-body infuser. So it's an infusion where the patient loads the pegcetacoplan into the infuser, attaches it to their abdomen, and then it infuses over 30 to 60 minutes. So that's how this one is given. Because it's subcutaneous and not IV, it does go through the traditional medication prescription pathway of approval, like access when you're trying to get this medication. Again, it has the same REMS as previous medications that we've discussed. So this one is the Valiant trial that led to the approval of pegcetacoplan for C3G and IC MPGN, also in 2025. So similar, this study did include adolescents, so age 12 to 17, or adults with biopsy-confirmed C3G or immune complex MPGN. It included patients with native disease and then a few patients that had post-transplant recurrence. They had to be on stable supportive care regimens, which is what you would expect. So they had to be on RAS inhibitors, they could be on SGLT2 inhibitors, they could be on mycophenolate, low-dose steroids. Same UPCR and GFR requirements as iptacopan, so greater than 1 gram per gram for UPCR and GFR greater than 30. And patients were randomized to pegcetacoplan versus placebo, again for 6 months. Primary endpoint of UPCR and several secondary endpoints that are listed here. In a minute, we're going to just take a look at the C3 staining that was reported with this study. So in this patient population, just pointing out, as I said, almost half were adolescents, so 44% were adolescents, and the remainder was adults, primarily white. And then you can see here the split between C3G and immune complex MPGN, more with C3G, about 80% had C3G. And then a few patients, as mentioned, had a history of kidney transplant, so transplant recurrence, 5 in the pegcetacoplan group and 4 in the placebo group. The median UPCR at the beginning was 2.4 grams in pegcetacoplan and 1.8 grams in placebo. And then here at the bottom, they have listed out the background therapy as expected. They're on RAS inhibitors, many are on immunosuppressants, less, 40% or so are on steroids, and then just a few, 10% on SGLT2 inhibitors. Similar figure here, we have the change in UPCR at 6 months in the pegcetacoplan group shown on the left versus placebo in the tiny little gray box on the right. UPCR was lowered by 68% in this group. Subgroup analysis tending towards favoring pegcetacoplan in all groups. And then, again, I pulled this one from the supplement because I'm visual, and as one who's educating patients on what we're going to expect with these medications, I'd like to see. So you can see over time, similar, by about, you can see, this is in weeks here, so by about 12 weeks, so 3 months, you really can see that decrease in UPCR in these patients. And then they did, again, although only 6 months, they did look at change in GFR from baseline to week 26. It decreased by 1.5 mils per minute in pegcetacoplan group and 7.8 in placebo. So you can see, it, to the eye, looks different, but time will tell. I think this is you.
I can take over here. From a nephrology standpoint, for us, seeing a decrease in C3 staining is very exciting with these types of agents. And so just presented here, you can see, if you're looking at the black background with the green staining, that's the immunofluorescence staining for C3. And that subsequent figure below that reveals a marked decrease in this. If you go to the table at the top, basically across the top of that table is the baseline staining. This staining, as you might imagine, is pretty much in the hands of the person rating. This is not a quantitative really thing. So it's rated from 0 to 1, 2, or 3 in intensity. There's obviously some fudging there a little bit, I think, as far as, one person's 2 might be another person's 3. But what this table is indicating is that baseline staining versus the follow-up staining at week 26, and basically indicates that people who had either 2+ or 3+ staining, those who were treated with pegcetacoplan, saw a decrease in the intensity of staining, in many cases to no or just 1+ staining. Those treated with placebo really didn't have that benefit. So it just indicates a pathological benefit that fits with what we think is happening by what we see in the UPCR and GFR data.
All right, and then just for completeness, looking at adverse events here from the trial, 40% of patients in each group reported adverse events related to the treatment regimen, with most of them being mild or moderate, about 10% with serious adverse effects or adverse events, and they do list out mild infections. So you see things like COVID, influenza, pneumonia, things that we would expect with medications that work in the complement pathway. All right.
Okay, I think I'll take over. Again, I was not myself involved in the decision about management of this patient. I think she's tolerating pegcetacoplan. There's no infectious issues to date. This is about 6 months into it. Still has hematuria and proteinuria at around the 1.3 gram level with a stable GFR. And I think this final bullet point is the key. I don't think any complement inhibitor therapy is going to help this person unless we reduce that 20,000 or so level of autoantibodies. So we have to, the same way we do with ANCA-vasculitis, lupus nephritis, et cetera, we have to tackle the source of the problem, not just the consequence of the problem. And this is a really key point, I think, in our use of complement inhibitory therapy. If it's something where the primary problem is the complement system, then it's a little bit simpler. We just block the appropriate area in the complement pathway. if there's a mechanistic reason for this, we have to tackle the underlying cause as well as the consequence. And so I think when we get back to Boston, we're going to probably give a little feedback to our colleagues there about the management. So let me shift to IgA nephropathy. So here we have a 24-year-old woman, also a fairly recent case, or at least currently what's going on with her is recent. So she has hematuria and proteinuria, 1.5 grams in a 24-hour urine done years ago. Serological testing, again, we don't know what the diagnosis is up front, was all negative. And back in 2018, she underwent kidney biopsy, which was consistent with IgA nephropathy, very little chronicity, so mild IFTA, and the EM demonstrated mesangial deposits that were comparable and corresponded to the 3+ IgA deposition on immunofluorescent microscopy. The MEST-C score was not reported in her original biopsy. And then her course follows kind of what we did in 2018 until fairly recently. So proteinuria improved somewhat to the 0.2 to 0.6 gram range. This, you can almost follow the history of our treatments with RAS inhibition initially, and when SGLT2 inhibition came into use, that was added, and people felt like that was a pretty good success at the time. And then in late 2025, the proteinuria bumped up to 1.2 grams, repeated, remained at that level, so there was a decision about further therapy. So which of the following would be the best treatment at this point? Would it be eculizumab, systemic corticosteroids, iptacopan, or rituximab? I think we're going to let that be. Okay, so we have the answer. So iptacopan. Oh, eculizumab. Thank you. Someone gave us some controversy here. And I suppose someone could have said systemic corticosteroids, except we're in a complement talk. So IgA nephropathy, for those not very familiar with it, the leading thought about its pathogenesis is what's called the 4-hit hypothesis. This begins with hit 1 in the Peyer's patches of the terminal ileum, with the release of what's called a galactose-deficient IgA1. And when that's in the circulation in some people, and no one knows quite why, some people develop autoantibodies to that. That's considered hit 2. And those autoantibodies in the Gd-IgA1 form immune complexes which deposit in the kidney. There is a wide range. It doesn't take much walking around this conference to not see a lot going on in IgA nephropathy therapeutically. So there's an interest in various treatments to reduce the formation of Gd-IgA1, including enteric-coated budesonide here in blue, in green, various APRIL and BAFF inhibitors in the blue in the upper left. In the old days, people tried mycophenolate. Older days, we've tried systemic corticosteroids with all kinds of side effects. But we're going to call attention today, I guess it doesn't get a box, to the things in the bottom, the complement cascade and the blocker of alternative complement in the form of iptacopan. Yes, we should be also providing renal protective therapy with RAS inhibition, SGLT2 inhibition, and even endothelin receptor antagonists. But the complement may play an important role in the pathogenesis. And I just want to return to this slide to remind us about this pathogenesis with the immune complex in the upper right, where if an immune complex condition deposits in the kidney and attacks the kidney, there's a wide range of inflammatory conditions going on. I'm just going to zoom in here just to show here an antigen bound to an autoantibody, resulting in activation of the various classical alternative as well as terminal pathway of complement. So there's an interest in potentially blocking this, and this is going to take us to iptacopan, and Anna will take over.
Okay, so this slide looks familiar. In that we've already talked about it. So this is a factor B inhibitor, as we've mentioned. It was approved for IgA nephropathy prior to its approval for C3G, again, oral tablet. I'm not going to spend a lot of time there. You've already seen it. So this is the study that led to the approval of iptacopan for IgA nephropathy, and it was the Applause IgAN trial.
So it included adults with biopsy-confirmed IgA nephropathy, again, on stable maximized RAS inhibitor therapy, UPCR of greater than a gram for 24 hour, and then GFR greater than 30. Patients received iptacopan, 200 milligrams twice a day, compared to placebo. This one was for 9 months. And at the time, so primary endpoint here was UPCR at 9 months, and at the time that I submitted these slides, the full 2-year trial to assess GFR slope had not been published, but it has been, so I've added that in. So we do now have GFR data. So this is our first complement inhibitor that we have GFR data on, so that's exciting. So this is the UPCR data, similar to what we've seen with previous medication. So you can see iptacopan shown here in the orange line, placebo in the blue line. You really reach that, lowering at about 6 months with this study. So left-hand side is the 24-hour UPCR, and then right side is just looking at the spot urine. So similar findings. UPCR is 38% lower in the iptacopan group compared to placebo. And then here's the adverse events for this medication. Most were mild or moderate in severity. And then this I added in, here's the GFR slope data that just came out very recently. You can see the top iptacopan decline, GFR slope decreasing by about 3 and about 6 in placebo, so significantly different. And just, again, this highlights, obviously this is helping maintain kidney function, helping prevent further loss of kidney function. Our new KDIGO guidelines really promote, GFR loss of less than 1 mil per minute per year. So doesn't all the way get us there, but absolutely part of getting us to that threshold of trying to maintain as much GFR in our patients as we can.
I think it's back to me. So I think Anna's point is really a very critical one. It gets at this mechanistic part. So we're going to have to think both what the clinical trials show and what evidence-based medicine shows, but also think pharmacologically, pathogenically, immunologically about what we're doing. This is an excellent drug. It reduces proteinuria. It slows the decline of GFR, as Anna pointed out, not to the level that the 2025 KDIGO guidelines and IgA is targeting. And similar to a lot of the things we've done for many, many years in nephrology, this is going to be an add-on to other therapies, that maybe those that reduce Gd-IgA1, maybe an add-on to things that are RAS inhibition, SGLT2, endothelin receptor antagonists. I think this will all be to be determined. But I don't think I really don't want this audience leaving with the message that monotherapy is going to be the right move for these immune complex or autoantibody disorders. Nevertheless, she's had a great result so far. So she started iptacopan 200 milligrams twice daily in October of 2025. And UPCR, if you recall, was in the 1.2 to 1.4 grams and declined nicely to 0.5 grams, at least in the check in February of 2026. At that point, her GFR remained stable in the 70 to 75 range. No infectious issues to date, but again, we're just talking 6 months. And I think as just a general point for all of these drugs, I think the longer people are on it, we unfortunately will see some infectious adverse events. To me, it's very much worth the trade-off of treating the kidney condition, which is going to have its own real and major consequence. But I don't think we want to leave here with the idea that these are people who are, never going to get infections. They absolutely will. This patient is due to see our center next month, and we'll have more information then, but not in time for this talk. So let's turn to the final condition, ANCA vasculitis, and our final case. So this is actually a fairly old case from Tufts. It's a patient of mine from maybe 6 or 7 years ago, who's a 66-year-old woman with underlying osteopenia, actually several years of recurrent sinusitis, GERD, and prediabetes. Came to our attention when she showed up in the ER with joint swelling, rash, and ankle swelling, had a petechial vasculitic looking rash, 1+ edema, and otherwise was not that unwell looking. Her creatinine was elevated with an AKI to 2.5 milligrams per deciliter. Her baseline was normal at 0.7, so this was a big decline in GFR. Urinalysis revealed 3+ blood and 2+ protein, and when we looked under the microscope, urine sediment revealed many dysmorphic as well as non-dysmorphic RBCs, and actually a bunch of red blood cell casts. So she underwent serological testing for the workup of glomerular disease, including all of the potential tests we send in people. And that said, as a result of what appeared to be glomerulonephritis with the hematuria and proteinuria, and the assumption that the rise in creatinine was acute, we initiated treatment for rapidly progressive glomerulonephritis with basically a GFRs declining in front of our eyes. So she received high-dose pulse IV methylprednisolone over 3 days. At some point in that course, underwent kidney biopsy, which demonstrated a necrotizing and crescentic glomerulonephritis with actually a fair number of both cellular and fibrocellular crescents, and no deposits at all on immunofluorescent microscopy, in other words, POSI-immune, GN. So this is basically an ANCA-associated vasculitis on kidney biopsy for those who don't look at kidney biopsies all day. Her ANCA titers returned subsequently with an anti-PR3 titer that was very elevated at 340. C ANCA positivity, as you can see. The remainder of serological testing was negative. So our final diagnosis was crescentic POSI-immune ANCA vasculitis, or granulomatosis with polyangiitis, formerly known as Wegener's. So in addition to corticosteroids, what would be the best treatment at this point? Would it be cyclophosphamide monotherapy, rituximab monotherapy, rituximab and avacopan, or where's the last one? Rituximab with eculizumab. Now this one, there may be some wide opinions about this. And I think if we waited a little bit longer, we might get some differing opinions, because there's a number of these that are very reasonable. If my next slide was the KDIGO guidelines on ANCA vasculitis, three of these answers would be acceptable. Induction of steroids with cyclophosphamide, or steroids with rituximab, or steroids with rituximab and avacopan. Why avacopan in this circumstance, which is what we did, would be the underlying conditions that she had with the osteoporosis or osteopenia and diabetes that would then potentially get worse with a prolonged exposure to prednisone. And so this was the thinking as we go through this patient. So here we come to this figure again. I'm going to hone in on the ANCA vasculitis. And just to emphasize the pathogenesis here, why are we talking about complement in an ANCA vasculitis? Well, it turns out, if you start at the top there, the neutrophils that are leading to ANCA vasculitis are expressing PR3 and MPO. These are the two tests we're running to diagnose ANCA vasculitis. In the presence of the ANCA autoantibodies, they're in yellow, attaching to those MPO and PR3 proteins, those will result in inflamed or red-looking neutrophil, resulting in vasculitis, the vascular damage, but also increasing the activity of the alternative pathway of complement. And this results in C5a being released, our old friend C5a, and it turns out there's a C5a receptor on the neutrophils, and what this does, interestingly, is it leads to more PR3 or MPO ending up on the cell surface, so it becomes a bit of a vicious cycle. So this is why this treatment seems to be appealing in ANCA-associated vasculitis. There's some preclinical data that would support why we do this. The complement system is activated, as I mentioned before, by the alternative pathway in ANCA vasculitis, and there is some renal injury mediated by C5a. And it turns out if you turn to preclinical experiments, mice who are C5 deficient are absolutely protected from being exposed to ANCA. Moreover, deficiency or blockade of C5a receptor provides protection. But in converse, and this is why eculizumab wasn't the right answer in these people, mice who are deficient in C6, in other words, they can't form the membrane attack complex, are not protected from ANCA vasculitis. So it looks like it's a C5a only thing, where blocking elsewhere in the complement cascade is not going to necessarily help people. I already mentioned the second point about the translocation of PR3 and MPO to the cell surface. And although C3 and C4 levels are normal, and this is one of the ways we make the diagnosis of ANCA vasculitis, is we expect it when we see normal C3 and C4. They're actually not normal. They're a little bit lower, but just not below what we call low. And it turns out if you measure C5a levels in the plasma and the urine in these people, they're higher than in controls or people with ANCA vasculitis in remission. And then finally, higher levels of factor big B, little b are seen in people with active disease. So this is the baseline data that's leading us to get to avacopan.
Right. We've made it to the last medication. So this is the fifth medication we're going to talk about, avacopan, as Craig mentioned. It does work sort of off to the side in the complement cascade. It's really C5a only, so ANCA vasculitis is really C5a only, so by blocking this C5a over here, it really has no role in the formation of the membrane attack complex, which is why this medication actually doesn't have a REMS. So all the other four do, this one does not associated with that increased infection risk with encapsulated organisms. It is 30 milligrams twice a day, and it's really used for, as Craig mentioned, its steroid-sparing effect when we're treating patients with our more traditional immunosuppressants for ANCA vasculitis. So this is the Advocate trial with avacopan from 2021. So this one's been around a bit longer than some of the others. Adults with ANCA vasculitis who are on background immunosuppression with one of three regimens, so either IV or oral cyclophosphamide, then followed by azathioprine or rituximab. And patients had to have a GFR of greater than 15. And patients were randomized to either receive avacopan or prednisone, which was tapered over 20 weeks. They had two primary efficacy endpoints in this study. So the first was clinical remission, which was defined as a BVAS score. So that's Birmingham Vasculitis Activity Score. Higher the score, higher the disease activity. So a score of 0 and no steroids for 4 weeks before week 26. And then the other efficacy endpoint was sustained remission. So remission at both week 26 and also at week 52 with no use of steroids there prior to the end of week 52. They did have several secondary endpoints, one of them looking at the steroid toxic effects according to the glucocorticoid toxicity index. So basically just looking at steroid adverse effects in both groups. You can see here, this is their primary endpoint. So for remission at week 26, avacopan was non-inferior but not superior to prednisone in achieving this remission, but it was superior to prednisone in achieving sustained remission at week 52. And then on the right-hand side, I just want to point out, again, they looked at side effects from glucocorticoids. You can see here on the top, I just included what the taper was. So obviously, avacopan group did not receive prednisone, but in the prednisone group, it was based on weight, and they started for adults at either 60 milligrams if they were above 55 kilos, or 45 milligrams if they were less than 55 kilos, and then tapered over the 20 weeks. And then down at the bottom just shows the steroid exposure in the two groups. And you notice that in the avacopan group, it's not 0. It's much lower than with the prednisone group as expected, but that's likely associated with the administration of the cyclophosphamide and the rituximab, so giving steroids with those infusions. And again, it's decreased after that first initial induction. But there were less steroid-related side effects with the avacopan group as expected. This is just their GFR data, just shows a little bit increase, about 3-point difference in GFR at week 26 and week 52, with the avacopan group getting a little bit higher GFR by the end of the study. Here's their adverse events listed. About 40% of patients had a serious adverse event. Most of them, about 10% of that was related to worsening of vasculitis. You can see the adverse events listed here. I do want to point out, okay, yeah, I got it. I do want to point out that there was a recent release from the FDA in April, so just about a month ago, related to hepatotoxicity and drug-induced liver injury with this medication. So I'll just highlight what the warning, the update said, was that there were 76 cases of drug-induced liver injury linked to avacopan, mostly in patients with Japan, so 87% of these patients were in Japan. 54 required hospitalization, 7 developed vanishing bile duct syndrome, and 8 died. Median time to onset was about 46 days, and most patients had a cholestatic or mixed pattern of liver injury. So they had elevations in total bilirubin and alk phos. And so then the FDA does now recommend, we were already checking LFTs when we were starting this medication, but they do now recommend just additional checks when we're putting patients on avacopan. So checking before you start, at week 2, and then week 4, and then monthly for the first 6 months of therapy, just to make sure that we don't see any of that with our patients. All right, so I'm going to spend just a couple minutes talking about the infectious risk with complement inhibitors. We've talked about it a few times in this, but I just want to give a little more data before I get to that. Just a reminder of sort of general adverse events, which I haven't talked about as the pharmacist here. I feel like I should just briefly point out that a lot of these medications, patients may complain of things like fatigue or headache, nausea can happen with any of them. I would say with pegcetacoplan, you want to pay attention for infusion site reactions primarily. Iptacopan does have an association with increase in lipids, so just making sure that when we're starting patients on iptacopan that we've got their cholesterol under control, lipid levels are good. Eculizumab and ravulizumab can have infusion site reactions, and then avacopan, the liver function abnormalities. So related to the infectious risk with these medications, excluding avacopan, this table just shows infectious risk with these encapsulated organisms for patients who had inherited complement deficiencies. So just pointed out here, patients with like C3 deficiency were, in this study, 40% of those patients 37% became infected with Neisseria, and 26% became infected with strep pneumo. So the infection can be real when it does happen in patients who have these deficiencies. Same thing with like terminal complement deficiency. Majority of the patients who developed an encapsulated organism-related infection was related to Neisseria. So we also see that this is looking at patients on eculizumab therapy for PNH or AHUS, and just pointing out that almost all of these patients here that are shown, I know this is very small, but almost all of these patients here are shown were vaccinated, and then there were breakthrough meningococcal infections. It's a time to onset, what's being pointed out here is that the time to onset of breakthrough meningococcal infections in these patients was about 272 days in patients with PNH and about 500 days in patients with AHUS. So it doesn't necessarily happen early, which is why, this is again why, some do continue that antibiotic prophylaxis long term, because we, can't be guaranteed that just because we vaccinated up front that we're not gonna have, breakthrough infections later. And the primary identified serogroup was group B, so meningococcal B. All right, so as a reminder, this is the vaccination schedule for our patients. So anybody that we're starting on these therapies, we do want to vaccinate against MenACWY. So the schedule is 0 and 2 months. And then don't forget about the booster every 5. So, some of these are newer therapies. We may not have gotten to the 5-year mark, but we will soon. So just making sure we have pathways in place to make sure we're getting these boosters done. MenB is at 0, 1 to 2, and 6 months. So that was pretty recently updated to add that 6-month vaccine. And then booster every 2 to 3 years after that. Strep pneumo and H-flu vaccines are a little easier. They're both just one time. And then we do prophylax with beta-lactams, typically penicillin. And when we're starting these agents, again, you want to prophylax until at least 2 weeks after you complete the vaccine series, and with an option to continue longer. All right, I'm going to spend just a couple minutes too talking about some of the practical applications here. So, these medications are great. We know that they're very effective. It's a very exciting time. Sometimes these medications are tricky to get. So just paying attention, to the components that we need to complete before we can prescribe these medications. So on the prescribing side, again, you want to make sure that if you're prescribing it, you're enrolled in the REMS for the medication if it has one, and that you get the vaccine started early. I would say that sometimes is a barrier for our patients. So when we've tried to have them get some of these vaccines in the community, they're not always available. So we, in our clinic, actually didn't stock all of these vaccines for a while, and we finally have now we stock them all. They can just come get the vaccines when they come in to see us. So if your clinic does not stock them, probably a good idea to advocate for that if you can. And then getting antibiotic prophylaxis started. And then regarding access, as I mentioned, most of these go through the pharmacy pathway, so just sent as a typical prescription, but our IV medications do go through the medical benefit. All of these medications, because they're rare disease medications, they are obtained through limited distribution, so that just means that you can't just send it to like a local CVS or Walgreens and the medication be able to be received by the patient. These medications are distributed by our a couple of rare disease specialty pharmacies. So just thinking about when we're starting patients who may have health literacy barriers or language barriers or other barriers, we really want to be thoughtful in explaining that they're going to get a call from somebody at a pharmacy that's not their typical pharmacy, and please answer the phone. And so just important to know, and I think sometimes overlooked when we're talking about the science of these medications. And then there's also a program start form with the manufacturer that sort of walks you through which pharmacies are used. It does require both prescriber and patient signature, so if you have that start form available when you're starting the therapy in clinic, I find that to be the most efficient way to get it going because everybody signs all at once. And then cost, right? We know these medications are expensive. A lot of the manufacturers do have PA and appeal support within their programs. If you don't have a pharmacy team that does that for you at your institution, they also have copay assistance and bridge programs that can help with getting patients on therapy who are appropriate to be on therapy. All right. That's it.
Okay, I think just in the last few moments, I want to do my best to see what the future of complement inhibition may look like without a crystal ball. But again, coming back to this idea of where we've generally started, if you think historically, we've started on the left-hand side with the conditions where the complement is really the primary role. So if we, pretty horrified to think how many years it's been actually since eculizumab has been approved. It's making me feel a little old. But so we started on that end of the spectrum, and now we're moving to the right and trying to pick up a number of these other conditions that complement has an important role, and others where maybe the role is yet to be determined. So just maybe as a way to summarize what we've been speaking about, the conditions we talked about today, C3G, we now have 2 treatments for it, both reduce proteinuria and stabilize GFR. For AHOS, again, 2 treatments with good improvement in the MAHA and TMA features, as well as improving kidney function. Avacopan for ANCA-vasculitis, maybe better rates of remission a little bit, slightly better GFR, steroid sparing. I suspect if we update our slides in a few months, we're going to say, yes, there is a REMS for this, for the LFTs, not for the infections. So I'm sure we're going to end up with a REMS program to monitor those safely. And IgA iptacopan, which actually the slide needs to be updated because it's from 2025, but it reduces proteinuria and reduces progression of GFR. So these are the things in the current state. In the future, complement levels C3 and C4 are low in virtually every patient with lupus. There's tons of complement staining on the biopsy. You can imagine complement inhibition could be part of our treatment regimen in lupus nephritis. A lot of times I see complement inhibition as a way to decrease our reliance on steroids for so many of these conditions and all the problems they cause. So I can maybe envision this might be where we go with lupus nephritis. Membranous nephropathy, clearly the anti-PLA2R triggers complement activation, and there's a number of investigations underway of inhibitors of complement. Diabetes, maybe a bit more of a stretch, although complement is at least somewhat involved. FSGS similarly. So just returning to this figure before we conclude, it's a very exciting time in complement biology. I mean, we can make some of these drugs bolded as approved for certain disease states, and maybe in the future we'll have additional indications. There are components of the complement cascade that we don't yet have inhibitors of, but we may very well in the future. And I think the future is really bright about a number of different indications as we collectively think about how this plays a role. I neglected to mention in the very beginning that, for those of you who are of my, vintage, med school back in 1990, what was it, 95, 4, basically taught the complement cascade. I won't name my med school. Thank God you didn't say where I went to med school. My med school said, you need to memorize this, and it's of no utility. And if there was, but you're in med school, so you must memorize this. If I had a time machine, I would go back to myself at that point in time and said, maybe pay attention to this a little bit more than you did back in the 90s, because it's really, obviously, a very important part of what we're doing. And I think the indications will only increase over time. So I think with that, the two of us are happy to take any questions.
Thank you both so much. I know the slides are sometimes busy, but breaking it down into each individual disease state was very helpful and where that is affected. Any questions for yes?
In C3G, which I'm admittedly much less familiar with, and recognizing, I guess, that it doesn't have a pediatric label, how do you view which patients a selection? It would seem very nebulous to me.
It's absolutely nebulous, both in adults and pediatrics. If you look at many things in pediatrics, almost everything we do is not FDA approved. So pediatricians are in the habit of getting things off label, and that's, I think, what they're going to do, in spite of there not being a label in their patients. If you have a C3G case or any of these other conditions, they're going to use the right treatments.
That's what I'm getting at. Do you see one more suited for more aggressive disease?
I don't think we know. What I think, these are early days of these two drugs. We're talking a total of about 200 patients in the combined trials. Those patients are undoubtedly very, very heterogeneous, right? Some had dense deposit disease, some had C3G, some might have been triggered by autoantibodies, some genetic, some might have had more disease activity, others had less disease activity. So I think it's too early to sort of know which treatment for which patient. I hope this comes with time and some clarity. It might come with some of the mechanistic understanding of the pathogenesis, the data we get from like the Morrill lab in Iowa and others that underline the pathogenesis will hopefully provide some clarity. But I think it's not going to be interpretation of clinical trials that gets us to the decision. I think it's going to be interpretation of pathogenesis, would be my best guess.
And I'll just add on a very practical standpoint, not that you want to hear that, but we're sometimes also limited by what we can actually get, what insurance will actually approve. So sometimes we want one therapy for a disease state, but we're told, no, you can't do that one until you try X, Y, and Z. So I think we also, on a very practical level, not that that's your question, but just something to keep in the back of your mind too.
Excellent.
Any other questions?
Right?
All right, with that.
Thank you, guys.
Thank you guys so much.
Thank you so much.